All right, so welcome back. I think we spent more than 6.5 minutes. I think it was 11.225, right? But I think we are here, so this is great. I'm just going to continue in my thread of thoughts about clinical pharmacy. We talked in the morning about the profession, and we talked about changing the profession. There is evolution in the profession. And then our job is to try to respond to these factors and begin to modify our profession and build new models to achieve our goals as a well-defined, successful profession. And I believe that the route for that is through education. So when we have any factors changing the profession, different things that can modify our goal or our direction, we have to respond to that. And we have opportunities. And we had also lots of missed opportunities. So I think the best way for us is to try to understand what's happening around us and then begin to modify our route. And I still believe that the best way to modify the route is to start by education. When we have new direction, new models, we have to prepare our graduates or our pharmacists to teach them the new tools, give them the tools, and get them more up-to-date and more advanced education to be able to perform and do the change. We're not going to do the change ourselves. We are getting old enough to not to change things ourselves, but we can influence the change process. And again, this is for the third time I say that, it has to be through education. And the good news is that that's exactly what's happening right now. As I discussed this in the morning, I said that there are lots of things happening to our profession. It's evolving, and now our job is to respond to these factors and these changes and take advantage and seize the moment and the opportunity. We don't want to lose another opportunity as we lost before. We lost lots of opportunities for our profession. You know, let me just give one name, that the opportunity for pharmacists to work in the field of radioactive materials and build a profession around these things. We lost it, but we lost other things also. Now we cannot afford to lose opportunities. Now we have opportunity. I'm going to explain to you. I think I mentioned something about that, but there are opportunities that are there, and it is into our side. And these opportunities actually are there for us to take it. We have to take it. How can we do that? Again, for the first time, through education. We have to prepare our pharmacists to be competent enough, to be professional enough, to be educated enough to perform in these new models. Otherwise, we are offering nothing, and these opportunities will be lost. So I'm going to focus today about what we are going to do to respond to these changes and what this affected our education or pharmacy education. I received my BS back from Egypt, 1976. So at that time, I received some type of education, which is totally different than what I'm doing right now. I'm now teaching, so I'm teaching different model, teaching different materials, different directions, different objectives, with different people, different students. It's different story, different game. So we need to understand the factors here and begin to adjust based on that. So I'm going to talk about the change, that trends in the pharmacy education that happened accordingly or based on the change in the society, change in the health field, the change in the way we treat our patients. And how can we adopt to this change and seize opportunity? We don't want to lose opportunities anymore. And then how can we move to make these opportunities or these moves a real successful one, building on success and compliance and assessment and proving evidence-based professional improvement. We have to show that we already improved our education, and this way we can say, hey, this is what we're going to do as a profession. So let's just think about it, and I hope that you can interact with me so you can give me your thoughts here. This is based on my experience from where I grew up, from where I worked. I worked in Saudi Arabia, by the way, sometime. I worked also, I had exposure to different schools in East Europe, even in Far East, and now in Canada, and then in the US. So I had some sort of exposure to different models of education, and I was following what's happening in the field of pharmacy and what's happening in the education process. And as you know, we started from the model, which is basically the simple pharmaceutical sciences model, where we teach students how to prepare the medications, how to analyze the drugs, how to make the analysis, and then how to sell these drugs. But nothing beyond that. Now the model is totally different based on different factors that happen here. We have healthcare challenges. There are changes here. I'm going to talk about this US system here, but I think we can, maybe with your help, we can just some sort of think about it in different models. I think in Europe right now, the model is beginning to evolve, and I can see even in the Middle East and the Far East, and I think sometime in Africa, they are starting to think about, especially in Kenya, starting to build some new models for pharmacy practice based on the healthcare challenges. So we have the healthcare challenges, number one. We have different students, different mentality, new generation. We have the millennial generation. These guys are totally different than what I was when I was a student, and what was my late dad when he was a student. Totally different. The way they receive information, the way they digest information, the way they even present this information is totally different. And also accountability is a factor here, because nothing is going to be happening if we don't prove that we are accountable to what we are doing. We have to show evidence-based education. So evidence-based is everything. In professional evidence-based and also in education. We have to show them that the outcome is well documented, the outcome is proved, and we show them that we did that. This is through the assessment process. These are requirements that are now, pushing us to change the way we do our business here. So let me start with the healthcare challenges. And basically, at least in the US, it starts by lots of factors demanding lots of healthcare workers. And this demand based on different factors happening here in the society here. America is aging. Lots of population now are above 55, 60. The baby boomers, now they are now 65, 70 almost. And these baby boomers now began to grow, and now they are aging right now. And this is a big population. So, and due to the increased, accessibility to medication, to therapy, to advanced care, now patients don't die. They stay longer time. So we have a real big number of population are aging. And those aging, personnel, we are really eager, or we are responsible to treat them. So we have to offer them healthcare, and this is big demand right now. This is one challenge. Maybe in the different countries, I think it's not that factor there like aging. I think the Far East is basically young population. We have lots of different, population is growing, and all of them are youth. So maybe 70% of the population maybe are youth. So this is another factor. So we have to look at it in different dimensions. We have to treat the aging population in the US, but also maybe in other parts of the world, we have to worry about, the younger population. But both of them has to be taken care of. Both of them has to be treated, and that's why there is a lot of demand for healthcare professionals right now. Also, you see every day, every other day, we have a new drug, new medication, especially for the new technology, biotechnology drugs right now for treatment of cancer and immune disease. And all of these factors here are increasing the pressure on us, because there is lots of drugs every day, every week. We have new drugs, registered, approved into the market. So I remember when I was in my pharmacy, 30 years ago, we had couple of hundreds of drugs. Now I think they are doubled or tripled. So we have lots of drugs right now, lots of medications. And now we began to have lots of knowledge about the effect of this medication, like the pharmacogenomics factors here. So the same drug, warfarin, that we used to treat patients with 30 or 40 years ago is different, because we discovered that the same drug can affect patient A in a different way than patient B, than patient C. And these factors are very important because this is life-threatening conditions. So now we have lots of information about medication, therapy, number of medications, number of reported adverse effects, toxic effects. It's huge forest, or I call it jungle of information that's around us. And the best profession that's really well suited to deal with this change are the pharmacists. So now there is big demand for pharmacists to take care of that. This is an opportunity. We have to step in and take advantage of that. The last thing is basically the dynamics of the healthcare. At least in the US here, the new directions right now from the Institute of Medicine is simply to allow all the patients, no exception, access to healthcare. No exception. And access is a key here. So when you say access, mean that this patient can have access to treatment maybe at home, maybe in the clinic, now in the pharmacy, in the hospital. Access should not be just only in the hospital or in the clinic. It has to be even in different areas. You can have home health care, across the board. And this is basically an opportunity because now we have demand for professionals to step in and offer that service. Till now, we are losing because nurses took over. Let's put it this way, in the US at least. They took over the primary care, professional work. So now they could push politically and maybe scientifically, and they graduated lots of nurses. They developed new programs, PhD program, nursing practitioners, clinical nurses, you name it. And they proved that they are efficient enough. And now they are licensed to treat. So they have now clinics, primary care clinics, run by a nurse who take care of the patient as a primary care professional. Pharmacists lost that opportunity. And I cannot give any excuse to the APHA, ASHP, all of these guys who are meeting every day and making parties and celebrations, and they are losing this opportunity. This is not an excuse. This is a crime for our profession. That's why we have to push hard and say, this is our right now to take this opportunity. Now there is lots of opportunities now for ambulatory care, for patient care, for lots of things that we can offer. We just need to educate our pharmacists to do it. And we have to produce well-educated pharmacists trained to offer that job. If we offer a wishy-washy pharmacy or pharmacist to offer this job, doesn't know what he or what she is doing, no way, we are going to lose again. We have to prove that we have a product that can deliver, and these deliverables are successful deliverables. So we have to look at education again, either by continuing education for our existing pharmacists through lots of all of these workshops, all of these certificates, all of this, even new licensing, and also for our graduates, we have to change the way we teach our students to make sure that they are ready to face these challenges. It's a perfect storm. Basically, we have lots of factors getting together and create an overwhelming pressure on us. And this is a storm that we have to ride. We have to be ahead of that storm. We have to really push hard to be successful and get out of that storm successfully. Otherwise, we are going to be left in the dust as we used to have all the time. We have to take that opportunity. This is very important. How? Through education. So what happened? And I'm just mentioning some examples here in the US, and I know that some examples also in Europe, I think in US, in Great Britain, in Germany now, even Germany that have classic pharmacy education, classic pharmacy practice, now they are moving into new models of pharmacy practice. Now we have increased responsibility of pharmacists to deal with chronic diseases, medication management, disease management. Now we have medication therapy management. These are responsibilities that are now taken care of by pharmacists. Also, we have drug benefit plan management. We have pharmacists who are specialized to make sure that you can modify that medication plan or the benefit plan, the insurance plan, to make sure that it can fit what we need to do for our profession. Medication therapy management, as I said again, this is a new star in our profession right now. And I used I built actually a center for medication therapy management when I was in Virginia. It's a very successful story. You have clinical pharmacists, taking care of patients with chronic diseases. They have an appointment with him or with her. He or she spend maybe 30 minutes to 1 hour consultation service, going over their medication, going over their lab tests, communication with their physician, with the nurse, going over all of these factors for the therapy, and then ending up formulating, we call it medication therapy plan or therapy plan, a well-detailed plan that's communicated with the patient. Even we give them, hard copy of their medication plan, and we already do some sort of consultation and go over these points with them. Then the patient come maybe after 2 to 3 weeks for follow-up, and then another follow-up, and then another follow-up, i.e. we are responsible for the medication management for this patient with hypercholesterolemia, with diabetes, with hypertension, whatever. This is an opportunity. This is a profession. This is a new profession, by the way. And by the way, we get paid for this consultation. So insurance pays us for the time we spend. Every 30 minutes, I think we are paid $150. This is really because unless you get paid for your service, it doesn't exist. If you offer service for free, it's not recognized. But if you are paid, this means, especially if you are paid by the insurance, you are recognized. This is a success story that it has to be spread all over the place. It has to be spread where you practice. It has to be spread all over the world. And I think there are some models like that in different ways. I think I heard about the UK that they have a different model. They have a prescriber pharmacist, a pharmacist who is specialized with a special education to offer specialized service to take care of patients with specific diseases. We don't have wishy-washy pharmacists who just treat everything. Nobody will know everything. But specialized service is very important. You have a pharmacist who is offering infectious disease specialized. I'm going through even certification now for infectious disease certification for an outpatient clinic because I would love to do something like that. I did lots of my work in the hospital with antimicrobial stewardship things, but I want to test it to see how can we offer infectious disease, service in the community at the same time for antimicrobial therapy. It's cool, it's beautiful, it's exciting. Also, pharmacists now are moving more into research and translational research, clinical research, and might add also practice-based research. You talk about outcome research, where you document your service. If I have an intervention for patient with asthma, I need to document my service by, i.e. pre and post intervention. I measure the factors, the clinical factors, the economic factors, all of the other factors, pre and post, and then I can document that. This is what we call practice-based research. This is huge right now. We need to work on these things. We need to prove that we are offering service and document it, and this is very important. Then I go to the last step, which is basically team-based practice, and this is the new directions right now. Interprofessional service is the key right now. Nobody is working the solo there. Nobody is working just to take care of the patient. You don't have that physician who just say, hey, I'm God. I can take care of this patient. Let me make sure that he is going to be treated. If he dies, okay, this is God well. I don't care. Nobody will ask me about these things. No, my friend, it's not going to happen anymore. You are working within a team, and each part of the team, each component of the team has some responsibilities. You are working with the physical therapy, you're working with the pulmonary therapist, you're working with the clinical pharmacist, with the nurse, with everybody, specialized service. Each one of the team will work together to have a therapy plan and monitor the patient. Because the key thing here is to make sure that we give the patient the best therapy possible with minimal adverse effect and the least expensive one. This is very important. So the team-based sort of practice is the key right now. So part of that team is a pharmacist work. So we have to identify our tools, our talents, our intervention, our key points, and be good at this, and then we can be part of that team. And again, this is also another evolution of our profession that increase our exposure as professionals who are offering therapy and treatment for the patients, not just only selling medications. So The health challenges are there. The second part is, so now we are changing all of our educational models to produce pharmacists who can follow these directions and actually be active in this new model. So now we are in our curriculum, where I'm now taking care of the education in Chapman University. We are building a new curriculum, which is basically integrated. It's evidence-based. It's basically, active learning process. We get them into cases. We get them to learn how to know about the drug, but also how to use the drug, and then know how to monitor the drug therapy. We just get them into that field, and we give them lots of training about, medication therapy management, about immunization, about, ambulatory care, diabetic care. All of these things are part of their education. We are trying to adopt our training, our education, to fill the needs. And this is going to be the success story. The second way we have to change our education model is to respond to our new customers. We have new customers here. We have the millennial guys. They are different. They are totally different. They spend at least 70% of their time on the computer or the cell phone or iPad or iPhone. They are computer experts. They are technology savvy. They receive things through the internet, nothing about books anymore, or literature or lecture. All of the things are garbage for them. They just want to get things through the iPad, iPod, broadcast, all of the things. This is a new way of thinking. And they don't believe in memorizing. They have to think. They have to find the solution themselves. They are smart. So they are different. So these customers, we have to change ourselves. It's difficult. We are used to do something classic for years, for hundreds of years. Now we have to change. There is no other choice. And that's what we are doing. So we change. I'm talking from my experience because I'm responsible for the academic program in the school. So we had to change the curriculum to fit with I think this College of Advanced Pharmacy Education from the AACP. They have criteria. You might go and check there. They have criteria to help us to build new curriculums that will fit the needs of our students. And this is very important. It's active-based, active learning. It's more into teamwork, interprofessional education. This is very important. And also the way we deliver this education is totally different. I remember I have lots of my colleagues. You talk about guys who have been teaching for the last 10 to 30 years, and then they ask them to do something different. They are crazy. They just say, hey, are you nuts? I was doing that for the last 30 years, and I'm a successful teacher. I do a good job, and I enjoy it. Now you want me to do it in a different way. You are getting me out of my comfort zone, and they are right. But sorry, we have to do it. Because we can't do the same thing that we were doing for the last 30 years. We have to change. Change is there. We have to adapt to what's happening here. So, for the curriculum change, we follow the CAP outcome, where you have collaborative work, interprofessional education. I have 3 courses right now for IPE, interprofessional education, where we meet with physical therapy, with physician assistants, with nursing, with medicine. And we have a course that's taught for all of them at the same time. And this course is basically case-based. In fact, next week I'm going to introduce to them a new program, a game, a video game. This is typical millennial thing. We're not going teaching. We're going to have a game for students to play together. It's a video game, and they play together. But this game is about a case, about a patient. So the physician, assistant will take it from that point, and then the nurse will take it from the other point, and then the physician will take it from that point, and then the pharmacist will talk about therapy and therapeutics, and then the physical therapy will talk about, physical therapy issues. The same case, but it has to be tackled as a team, and this is exactly what happens in the real world. You have a patient, and you have a team working with them. We teach them, we train them how to do these things in a game format, so they love it. I remember that we had some sessions, students loved it. It's just beautiful for them. It's just each one has a computer, we have a game, and then the game is in the cloud, so they share the same game, the same patient, and say, hey, do that, add this drug, remove this drug, do this diagnosis, do these things, in the same case, and they are connected to each other. They love it. This is the way they do it in the game, I think Game of War, something like that, which is famous game. The same model. They love it. It's education by playing through games. And they love the things. And this is typical millennial, approach. I'm lucky because I have lots of time to talk, so they gave me permission to talk double time because there is not enough speakers. Lots of the speakers already could not make it to the conference here. So I was confirmed that I can talk more than what I should do. So I'm feeling comfortable now. So bear with me. So we have interprofessional education. Leadership, we have to have leaders. We don't have to have those guys, bookworms who know how to memorize and get an A, and they are really bad personnel. They are not really good, leaders. They just know how to memorize and get an A. We don't like these guys. We prefer someone who is active, proactive, thinker and leader. This is very important. Personality is important. And then we have to have a student or a pharmacist who know how to deal with technology. You have a guy who is 61 years old like me, who I was lucky because I like technology, so I trained myself with that. But I know that it's difficult for us to go and learn new technology, new programs, new programming, new things. It's difficult, but we have to, because we have to train our students or our future pharmacists how to use technology, because this is the future. You are going to have technology everywhere. In fact, there are lots of iPads right now, or maybe iPhones right now, and maybe small handheld computer, handheld computers that you can use it for following the heart rate and blood pressure and maybe some diagnostic things. Lots of health-related issues are on these apps. Lots of apps. I just purchased an app yesterday that to try to do modeling for treatment. Everything is through apps, through computer programs, and in fact, not even computer. Now the iPad and the iPhone and the Android is the key right now. So we have to learn these things. We have to learn how to do things, because this is the future right now. We prepare our students, but also we prepare ourselves for that. Now, also, we have to change the way we teach our students. What's the classic teacher style that we used to have? The same thing that I'm doing right now. I'm standing here, tell you what I know. You are sitting there, listening to what I say, maybe are interested or not. Some of you guys maybe fell to sleep. Some guys will say, oh, what is this guy doing here? I don't care. I don't want to listen to these things. This is classic lecture. It doesn't happen anymore. We are still doing that in conferences, but I wish sometime in the future we can have some sort of interactive model there. Now in the classroom, there is nothing like that. We have to change the way we teach our students. The way of active learning pedagogy is very important right now. And now what we call it pedagogy, I call it andragogy, by the way, because we are dealing with older. Pedagogy is from pediatrics. So this was developed for children to learn how to learn. But now we are dealing with grown-up adults, so I can call it andragogy. I'm going to change that. And we call it flipping the classroom. So changing the classroom dynamics. So other than teaching, and you guys are receiving, no, I'm not going to teach anybody anymore. I'm going to sit there and allow you to learn. So it's not teaching anymore. It is learning. And this is far more comfortable, far more powerful to get the learning process other than the teaching. This is what Einstein did a couple of decades ago. He just said it, and this is very brilliant. Nobody knew that, but this is really brilliant, other than inventing all of these beautiful things. He said, I never teach my pupils or my students at that time. I only attempt to provide conditions in which they can learn, period. And that's exactly the essence of what we're doing right now. We're not teaching them anymore. We are going to get them into the condition and the mindset and the way and guide them to learn how to learn. It's a lifelong learning process, journey, and we are going to help them to get into that stage. So based on Bloom's taxonomy, all of us received education at that level, which is memorizing, remembering. You remember when you was in the classroom? I used to hate my A student friend, who is the A of the class. I wasn't, really the top of the class. I was maybe number 4 or 5. But I hated this guy because he just had a memory that's really super memory. This guy could just give me the textbook and say, hey, Ayman, can you just please, listen to me? And he just typically says what's happening in the textbook, page by page. If he said me, change the page, please. Okay, thank you, my friend. He is just a genius in memorizing. Is he a smart person? No. He just has one talent, which is memorizing. But the problem with that, our education system at that time was favoring those memorizing things. So you have all of those guys who got A or straight A's are the ones who are really able to memorize things and have photographic memory so they can get good A's. But you can have lots of smart guys, innovative guys. And it was proven when they graduate. I could see that. I made some sort of study to see what's happening to our graduates, those who got A's and really top of the class, where they are right now, what they are doing. And those who did not get A's, but they are okay, maybe B's or A minus, whatever, but they are not really top A or top of the class. They did better. They are innovators. They built companies. They built even schools. Some of them actually are deans of schools right now. I remember a friend of mine who was one of the, I think he's the richest or the most successful pharmacist in Egypt right now. He was failing the courses. He was a C or D student, but he is the most successful pharmacist. And this is really amazing. It tells you the story here that to be successful in your profession, you don't have to be with a memorizing. You just need to have an innovative leadership, open-minded, and an entrepreneur type of thing, eager to learn and know how to learn, not just memorize. So now we are moving from the memorizing to the understanding. No, we are getting even more. We are now teaching students how to analyze the situation, how to evaluate the condition, and how to create and develop something new, i.e. treatment plan. This is what we want them to do. We don't care about memorizing. I'm not going to have a patient and say, oh, you have hypertension. Oh, hypertension is a disease that's caused by 1, and this is what's happening, and this is the treatment. It's not going to go anywhere. The patient needs from you a thinking process. Oh, you have hypertension. What about the heart rate? What about the blood pressure? What the other drugs there? Is there something that can influence this blood pressure? Is there some medication he's receiving? Is there some food thing that can affect that? What about the salt? What about the levels? And then get things together and then say, hey, you need to do these things. These are the plan, or this is the plan that you want to follow to get really good control of hypertension. Not by just telling them everything about the hypertension in the textbook. So now we are shifting more into analyzing, evaluating, and creating, which is more important thing. Do you remember a movie called Rainy Man? Do you remember that? Tom Cruise with Dustin Hoffman. Yeah. And this guy, he had autism, right? A type of autism that is basically, he is genius in memorizing. Only memorizing. So I remember that, this is a beautiful scene. I remember that when Tom Cruise gave him a phone book, he literally memorized the phone book. So he could go over it, and he could tell him, page number 5, oh, these are the phone numbers, and these are the names. Page number 7, these are the phone numbers. That's wonderful. So this guy is an A student. This guy is brilliant. But when he gave him a phone and told him, can you dial the number, please, for me? He couldn't. He couldn't. Because he knew how to memorize, but he didn't know how to use this knowledge to do something, to evaluate the situation, to create something, to do something. So we are looking for guys who know how to do things, not to memorize things. This is exactly what we are going for right now. So now the dynamics in the classroom are different. We are dealing in a classroom in a different way. We used to have the lecturer standing here, and the students are there, and then I give them all the information, they receive it, go home, memorize it, do the homework, come to the exam, vomit the answers, and then forget the whole thing. That was the classroom, right? That's what I was raised, the way I received my education. It's different right now. Now we have the lecturer standing there, doing nothing. all the information was given to them a priori. And in fact, not all the information to memorize, all the directions, how to dig in, how to find information. Go and dig in and find articles about the treatment of hypertension. By the way, there are guidelines, find it. What the recent guidelines? By the way, there's a video there about the treatment of hypertension. And by the way, this is my lecture. So I used to record my lecture. This is what I'm going to tell you about what the knowledge there. Here it is. Listen to it. Dig in, find information. Read articles, read the guidelines, learn about it. Google, find everything. So you come to the lecture with the knowledge already digged in and found, and you got it, and you spend the time and the luxury and the knowledge to find it yourself. So the knowledge that you find it yourself is far more effective than the knowledge that you get it from somebody else. When you dig in and find something, it is there. It doesn't go away because you spend some time and effort to find it. Now we come to the classroom. I don't lecture you anymore. We go together in groups and we go over cases. We go over discussion. We go over important points. We go over, play a game. We go over a game, and we try to interact. And within that process of interaction, the knowledge that I gain through finding it gets there. When I get a case and begin to think about it, and then my friends say an idea, I get an idea, and then an opinion, another opinion, and then I give them my opinion, and we formulate something together. This is education. This is active learning. That's why we call it active learning. So the lecturer or the professor is not the sage on the stage as you saw it. He or she is simply the guide on the side. That's the exact expression that you used to have here, just to guide. You are not a professor anymore. You are not a teacher anymore. You are a guide. You are a preceptor. You oversee the activity. You try to roll that activity and make it more active. So in the traditional education, you have the teacher there and everything around him. He is the professor, so he is the one you have to get afraid of because he's going to give you an exam. Information he tells you or she tells you is there for the exam. And he's threatening or she's threatening you because this is going to come in the exam. This is a question exam, information for the question exam. This is a really threatening environment. It's not anymore. It's knowledge-based, just the knowledge to memorize it. One size fits all. I give you the information. You are going to adopt it. You are going to understand it. You are not going to understand it. You're not going to even think about it. You forget it. You are sleepy. I don't care. It's just I'm telling you everything. One size fits all because we have different levels of education, different level of thinking and receiving information, different way of absorbing information. So we have to consider that. In the traditional way, we just one size fits all. These are the information. Memorize it. I don't care. That's it. And what we call it here is a passive learning. In the new model here, we have education is student-centered. You are going to dig in and get the information. You are going to teach yourself how to do the things. You are going to find the new knowledge yourself. It's a performance-based. I'm going to test you on your performance, the way you find the thing, the way you perform, not the amount of knowledge that you can memorize from you. It's a differentiated instruction. It's because I deal with each student in a different way, based on his or her way of thinking, if her way, mental status even. Some student may be depressed today. I have to deal with him or her at that level. Some student is just active. I just deal with him or her at that level. It depends. It's personalized education, as I call it. And it's active learning. I'm going to go over that. So just simply we have everything before the classroom. And then when we come to the classroom, we come and do role play. We have practice-based. We have cases. We have different ways of assessing that. There are challenges. I'm not going to go over that, but it's very important. The most important challenge that the professors themselves, they feel threatened because this is a new thing. You are asking them to redesign the course. You have lots of faculty work, and they are going to be very resilient. And you have to give them professional support. You have to have a system around them to help them to do all of this panopto recording. They have to learn how to do this technology. You have to have some support system. You don't leave them and say, hey, fill up your classroom. You have to give them support. And what's more important, that you have to convince the students to buy into the process, because these guys came from high schools or maybe college with the old way of learning. Now you are showing them a new approach. It's a transition for them. You have to get them into that. You don't just push for them. You just get them gradually and get them to learn this process. So this is the third part here. After you do all of these things, you have to show accountability. You have to show what you are doing is right, that the results are positive or negative by doing assessment. And this is very important, that whatever you will do, you have to assess it. You have to have continuous assessment. You set the goal and the approach, and then you gather the evidence by assessment, maybe formative or summative assessment. But what's more important is that the data that you get from this assessment process, you don't throw it in the garbage can. Or don't say, oh yeah, I had all of these evaluations, and I got at least 5,000 evaluations on my desk here or on my desktop, and we did a great job in the assessment. No, you have to use this data and show that you analyze this data. You have spent a lot of time analyzing this data and getting lessons out of this data, and begin to change direction based on what you found in the outcome here. And that's what we call it, close the assessment loop. You have to use the data to begin to change your goals, change your approach, then do assessment again, and then analyze the data. If there is change, you change and continuously. This is what we call it, closing the loop, which is very important factor in the education process here. Let me give you this is my personal vision and reflection to make sure that you can, if you want to take care of an academic program, these are the steps. I tested that, I did that sometime, I was successful sometime, failed sometime, but simply you have to set the goals and develop short and long-term plans. You have to have the faculty involved in that. And then you have to maintain viable, build a competitive academic program that meets, at least here in the US, the ACPE. I think there are some sort of guidelines in different countries. I think ACPE is now expanding to just oversee lots of other programs, and I think that they are successful in helping other programs to educate pharmacists. And then you have to make sure that you take care of your faculty through faculty development, improve their talent, improve their capability, and also set a culture of partnership. You have to build a team, and each member of the team has to be responsible for this type of things. This is how we can get ahead of the storm, and this is how can I say thank you, guys. So, if there's any question, please.
Thank you, Dr. Ayman. I agreed with all what you said. I want to say that I don't get the priority or the chance to go to America or Canada or to learn about clinical pharmacy, but I lived all what you said, I practiced it already. First, I want to talk about documentation, which is very important for any clinical pharmacist want to establish a service in a hospital. Documentation is very important because I worked as a clinical pharmacy in about 7 subspecialties in 7 different countries in Egypt and Saudi Arabia. To convince the community, starting from the hospital director to the residents, consultants, pharmacists, we have to document everything that we are doing. All my interventions and recommendations with the patient file, age, name, and everything I document. And finally, I got to this, my poster, which will be presented in this conference. It is that comparison between the different types of medication errors in 4 different hospitals in 2 different countries in the Middle East. The study period was from 2005 to 2015. In each hospital, because I worked in oncology, then I went to tertiary hospital, internal medicine department, then to pediatric hospital, then finally to cardiology center. So I'm comparing the incidence of medication errors or my recommendations in these 4 different centers through my data that I collected over a period of 10 years through my documentation. I selected 100 files from each hospital, and to get this data, I have to work for 10 years. Without this documentation, I cannot I established the service in these different hospitals, and without nobody in 2005, nobody told me that I have to document, but I felt that I have to document. Otherwise, if I'm not documenting, I'm doing nothing. Nobody knows what I'm doing. What's my job description in these countries, in these hospitals at this moment? The other thing is a successful story. Yes, we have to convince the community with a successful story. In 2012, because the quality requirements in the hospitals, they started to make something like improvement projects for the pharmacy department. And when to make these improvement projects, they asked the pharmacists to participate. So I participated in making an improvement project for the pharmacy through also detecting the medication errors or drug-related problems, because this is my PhD thesis. And finally, I found that about 60% of errors occurring during prescribing, 58% occurring during administration by nurses, and 55% occurring during monitoring. And I made an improvement project of 5 steps. The first step is implementing the clinical pharmacy services. The second step is to educate the staff about the most common errors that I detected. Then in our hospital, there was no IV admixture unit. So I recommend that we have to have an IV admixture unit to decrease the incidence of medication error in administration. Then establish a drug information center, and the pharmacist has a role in the drug information center. So this was one of the recommendations. Over a period of 6 months, I decreased the incidence of medication errors from about 60% to 10%, which is the benchmark in the international guidelines. So a successful story should be published, and everybody in the hospital should know about it. It is a successful story, so everybody should know. The other thing is using the technology. In 2005, I was working as a clinical pharmacist. Every day I'm seeing different cases, different drugs, different adverse drug reactions, and I want to collect cases for my PhD. But I cannot memorize all the side effects, all the dose adjustment in renal and hepatic impairment, all the interactions. I cannot memorize. So at this 2005, I got this ball, the pocket computer, before the now Micromedics and Medscape and Lexi, everything is in our mobiles. But before mobiles in 2005, I brought this Lexi pocket computer. It was a pocket computer. And all the time, all my rounds, I always checking. I cannot memorize millions doses of different drugs. I cannot memorize. Some needs dose adjustment in kidney, some need dose adjustment in hepatic. There is interactions, there is contraindication, relative adverse drug reaction. So I have to have this technology. And I started using this technology from 2005. And it was very successful. By this technology, I worked in many other different subspecialties. I'm so sorry, I was so long. The final comment.
Can you have a speech and present all your things instead?
Huh?
Can you have your own speech and present that in a separate thing? Because
We just have her finish.
I have a presentation.
wait for your presentation.
Finish.
I have a presentation about my booster by chance in my flash memory. So if you want, I don't mind. The other thing is that I worked as a lecturer of clinical pharmacy, and I'm now a clinical pharmacy preceptor and assistant professor of clinical pharmacy collaborative, because I'm in the hospital in Qasim University. And I experienced using the team-based learning in our students. Actually, there are many challenges and many barriers to use this system. I'm talking about my experience. The first thing is our students are not familiar with this system. It's only, we started to apply it in the college, in the university level. So primary and secondary level, they don't know anything about this. So they cannot, as you mentioned, they cannot understand. The other problem is we are giving the students one chapter from applied therapeutics to read and understand and summarize in 1 week and come for the exam, and the exam with marks. And we give them 10, 20 cases to actually, the pathophysiologically, يعني, they cannot understand, they cannot, it's very, very problem. Yeah. The other problem is it's decreased the level of the educator.
Yes,
because
I think having your own presentations.
Let me just...
I need to know if you have any questions.
I think let me just have some comments here. I think I appreciate what you are doing here. You know, I really applaud your efforts, because I can see that you are sincere in your profession and you are struggling. Because we struggled all the time. You know, I know that. But just to go over these things, don't feel upset because you are not here in the US or in Canada because you're not learning clinical pharmacy. Clinical pharmacy can be anywhere. You don't have to be here physically to learn it. You can have it there by just having education, continuing education, access to these things. And there is lots of accessibility right now. And I know that from Saudi Arabia, I know that because I know that the ACP is working hard to push for these things right now. Number one. Number two, for the technology things, yes, you are right. I had the same experience. It was 1997. I got my first PDA, and I was always going through the same issue, and this is the best solution. Now, we don't have a problem like that. Every there in the PDA, you don't have to worry about carrying all of textbooks and memorizing anything no more. Now, for the experience with the team base, this is culture change. And to get it, you have to build it. And as I said here in my first moment in my speech here, everything could start from education. You have to educate your new graduates, your pharmacists, how to work as a team, your even physician students, your medical students, nursing students. Everybody has to learn this culture. You have to learn working together. In the classrooms where we grew up, you have each student alone. But in the US here, they work in groups. This is a good thing about education. They teach them how to work in a group, in a team. And this is now is going to be reflected in the higher education, that we as professionals will work in a team. Once you have this learning module from the education, it will jump into the profession. So you have graduates who know how to work together, understand the advantage of a teamwork-based things. Okay, thank you again.
So, thank you very much.